Welcome to Combos from the Couch by Lifestance Health, where leading mental health professionals help guide you on your journey to a healthier, more fulfilling life. Hello, everyone, and welcome to Combos from the Couch by Lifestance Health. I'm Nicolette Lianza, and on this episode, I'll be talking with Paul Brasler, a clinician from one of our Lifestance Virginia offices, and he'll be helping us to understand more about substance use disorders. So welcome, Paul. Great to have you on.
Thank you, Nicolette. Thank you for having me.
You wrote a book called The Clinician's Guide to Substance Use Disorders, Practical Tools for Assessment, Treatment, and Recovery. And your book covers so many aspects of substance use disorders, like the science behind it, treatment and strategies for it, even the language we use surrounding substance use disorders, and such an important point too of emphasizing the individual as opposed to disorder. So I really look forward to sharing your insights on those who may be struggling with substance use disorders.
Okay, sounds great.
So let's jump in and have you tell us a little bit about yourself.
Well, I'm a licensed clinical social worker, and I work I live and work in Central Virginia in the greater Richmond metropolitan area. I've been with Lifestance now for 6 months. This is one of two practices I'm with. I have another practice where we practice ketamine infusion therapy, which is kind of a whole other subject on itself. But for Lifestance, I work with individuals 15 and older. And my background, though, has been in substance use disorder treatment and treating people, what are collectively called high-risk clients. In other words, psychiatric emergencies. So come to Lifestance with a lot of experience in community mental health, teaching as well. I also work, I'm a national speaker for PESI. So appreciate being a part of the Lifestance group because frankly, the flexibility is huge, and the independence. I like being able to do what I like to do, and frankly, being left alone to do it and given the tools I need to do it. And it's been really cool.
Yeah.
Yeah, I've been a social worker for close to 30 years. Have a family here. I have 3 sons. My wife is a trauma nurse, and so we have a lot of fun.
Sounds like you and your wife both do very important work.
We like to think so. We joke that if we talk about our work like at a party, we could kill the conversation in about 30 seconds. So we don't.
So tell us about what inspired you to write this book.
Well, so I went to grad school at Virginia Commonwealth University, go Rams, in the 1990s, and at the time, I had exclusively worked with kids that were coming from significant economic stress. A lot of kids who've been abused. I was working in residential treatment at the time. And the school asked me, where do you want to do your first intern? Where do you not want to do your first internship? And being really naive, and I talk about this in the book, but I said, I don't want to work with addicts. And I wrote it in big letters. And I think I even wrote because they can help it. And my prejudice toward people with substance use disorder was grounded in the fact that nearly all the kids I worked with in residential had been there or were there because of neglect, abandonment by parents with substance use disorders. So I had a very negative view of that.
Yeah.
And so the school, in their wisdom, put me in a residential program for women who were IV drug users. So I was like, okay, clearly I got caught, and I got tricked. But I went there, and that was the summer of 1997. That was a profound, career-changing, and maybe even life-changing event because as I got to know the clients there, I realized there was really no difference other than age than the kids I would work with at night in my residential program than the folks I work with during the day. And I became fascinated with how molecules, various substances could change how people think and act, how drugs could override a maternal instinct or paternal instinct or even survival instinct. and I became fascinated with it. And so as I graduated and as I continued my career, I gravitated towards substance use disorder. But in my field of social work, there was not a lot of, at least in my corner of the world, there was not a lot of information, not a lot of educational opportunities for it. So I began educating myself. At the time, and still in many places now, services are siloed. At least
Hmm.
in public services here in Virginia, for example, if you go to a public state-funded mental health clinic, you will often be funneled into a mental health group or a substance use disorder
Right.
group.
Right.
Even though, as I say in the book, about 80% of people with a substance use disorder have some level of a mental health disorder and vice versa. It's the outliers that are pure
Right.
serious mental health illness or pure substance use disorder. But our systems of care and our education systems are slow to catch up.
Yeah.
So when I went back to my alma mater in the 2010s and said, I want to teach a class on substance use disorder. And they said, great, develop it. I said, I thought you'd never ask. So I did. And that kind of became some of the foundations of this book. But my main reason for writing it was I really want to close the gap in the knowledge base for many clinicians, and not just clinicians. This book is appropriate for first responders, for clergy, for teachers, even for folks that are not in the field. It says clinicians guide because that's what the publisher wanted to say. It's more than
Gotcha.
that. But the idea behind it was to close that knowledge gap, to demystify substance use disorder, and to really humanize people who live with substance use disorder.
I love that. It's a humanization of it. I too, as I was navigating graduate school, was locked into the thought of like you have those who have mental health in this category, and then you have those who are struggling with substances.
Right.
And yes, they can cross, but really you're taught like this category
Yeah.
and this category. So I'm really glad we are eventually, and we are slow to catch up the
Right.
often the field, but to evolve beyond that for
Right.
sure. How would you define addiction?
I use a couple of different definitions, but the best definition I got is from a book. The author's name is Morgan, but the title of her book is Addiction, Attachment, Trauma, and Recovery. And I love her definition, and I'm just going to read the quote.
Yeah.
So she says, addiction is a multi-determined phenomenon with layers within layers of mutual influences, internal and external, all interacting concurrently, leading to a pathological outcome. She goes on to say it's no more true to say that addiction is simply a brain disease, a flawed personal choice, or an experience of learning than it is to say that falling in love is nothing but biochemistry.
Mm.
And we've come a long way in the field in terms of conceptualizing substance use disorder, or which is another name for addiction, substance use disorder, as a medical illness that has characteristics that are very similar to asthma, hypertension, diabetes. But the movement within the field now is to move even away from a medical model toward a recovery model. And by recovery, what we mean is, read the definition of that, is that it's a lived experience, improved life quality, a sense of empowerment. It's a process. And
Mhm.
so while we've utilized the medical model to legitimize and support treatment and hopefully lead to destigmatization of SUD, we really have to look toward the recovery model to realize that that is about individualizing practice. And if I'm sure many folks are familiar with the Association with ASAM, so the
Mhm.
American Society of Addiction Medicine.
Yep.
They talk about treatment has to be individualized, just like any other type of treatment. And I think medicalization has helped that. But recovery is not just looking at the addiction itself. It's looking at the whole person, which is really in line with everything else we do as clinicians.
So why is language surrounding addiction important?
Well, language is power. And I used to tell my students, or even people I train now, I said, I'm not politically correct to be politically correct, but I'm not going to go out of my way to offend people, because that's really, language should be used to draw people in.
Mhm.
And addiction, and particularly like words like substance abuse. Abuse is a very negative connotation. We think of
Right.
child abuse. That's bad.
Right. Right.
And even with addiction, I will talk about it. I will talk about addiction in the global scheme, like addiction treatment. But if I'm talking with a patient or about a patient, I'm going to talk about alcohol use disorder, benzodiazepine use disorder, opioid use disorder, because I really want to make it about the individual. That
Hmm.
just as we would not say, "Oh, Susie is bipolar," we would say, Susie lives with bipolar disorder or
Yeah.
has bipolar disorder. We want to keep the person
Yep.
first. There's still stigma is one of the reasons, one of the primary reasons why people do not seek treatment. One study showed, for example, it was actually a meta-analysis showed that uh, family members, families with a member with substance use disorder felt more isolated in their communities than families that had a member with schizophrenia. Because
Wow.
there is still this notion of it's all the person's fault.
Hmm.
Now, there
Hmm.
are elements of choice in this. And then I also believe that people are not automatons. And so what we mean by that is that there are elements of choice of, does a person want to try to engage in treatment? Or do they want to engage in, harm reduction strategies? There are elements of choice in that. But as I tell people at the beginning of of a presentation, whenever I talk about substance use, I've never met a person in close to 30 years of doing this kind of work in various settings. I've never met a person who can look me in the eye and say, "This is what I wanted to have happen to me. I wanted to be an adult living in precarious situations, sticking a needle in my arm every 6 to 8 hours. Nobody wants this." Or I wanted to be able to drink myself to oblivion, or whatever substance we're talking about. Nobody wants that. Some people
Right.
have been told that is what they are destined to become, and they believe that. But
Hmm.
the example I give it is, my youngest son, Eli, is going to be 11 this summer, and Eli loves basketball, and he's been playing on a fairly competitive team this year, and he's a great assist. Hasn't made a shot all year, but he hustles, and he's like, I want to be professional. I want to play basketball in college. Love my son. I'm going to encourage him. The chances of him playing for a Division I university, probably not going to happen.
Okay.
But he doesn't look. But at the same time, we're going to encourage him in those
Of
dreams.
course.
He
Of
doesn't look
course.
at me and say, "Hey, Dad, when I grow up, I want to be an alcoholic."
Right. Right.
And so even though he has probably a 1 in 10, maybe even 1 in 8 chance of developing a substance use disorder. So it really, the language, the last thing I'll say, but it really is about moving toward a we
Hmm.
mentality as opposed to an us and them, they, those. We have enough of that in our society now.
Yes.
This is where we heal these divisions. And what's interesting is that when you really talk with people about substance use disorder, that people, everybody is affected by substance use disorder in some way, either directly or somewhat indirect. Everybody knows somebody or some buddies
Right.
who
Right.
struggle with this. Um, this is an area where we can agree on, and this is an area where in a lot of the political systems within our country, we're actually seeing a lot of bipartisan support, because we're realizing this is a phenomenon that does not care who you voted for, doesn't care about the color of your
True.
skin. It doesn't care. It's an equal opportunity killer.
You made a point in your book, language drives stigma.
Mhm.
And that was very powerful for me to take a look at because that's so true. So it's so key that you're emphasizing language as we're
Yep.
talking about this. Again, my graduate training was very much like the addict and like just, are
Yep.
they clean? Are they dirty? And like just that
Mhm.
language is so stigmatizing. So I really love the fact that
Yep.
you emphasize the language and how important it is in the book.
Well, and with that is that one of the biggest things we also see, and I talk about this in the book as well, is self stigmatization of the person with
Mm,
substance use disorder. Addiction becomes a self fulfilling prophecy. If you look at how intrinsically linked it is with trauma, You really, I mean, you really cannot separate the two out. There is, for the majority of people with substance use disorder, there is some trauma history there, of different types, different
Right.
levels,
Right.
but it's there. And so, and part of what I saw, particularly when I work with folks who used heroin, I spent a lot of time with folks who inject opioids, heroin and fentanyl. One of the things that we saw as they entered recovery, particularly with medication assisted treatment or medication for opioid use disorder, um, they would be like, I'm dealing with my feelings now. What the heck?
Right.
So they wouldn't say heck. They'd be like, what is going on? I haven't dealt with these feelings in 7 years. And so as a team and as a group and as peers, we're having to say, okay, we're, because again, those feelings are going to drive a return to use,
Mm-hmm.
because I want to go back toward that sense of oblivion.
Right.
And
Right.
so, we have to recognize it, particularly as we delve and really recognize the full landscape of trauma. And let's be honest, most people coming to us for therapy, um, it really is about a lived experience of trauma more than
Yeah.
anything else. And,
Yeah.
and again, I don't think every bad thing that is a trauma. I'm not saying that, but think of how many clients that you all out there might have
Right.
that, I have bipolar disorder, but they've never had a manic episode in the absence of substances. They've never had all these other things, and it's like it's about trauma. So
Yeah.
we also have to look at how bad diagnoses have
Yeah.
have helped people to miss opportunities to treat their substance use disorder and their trauma.
How can working with people struggling with substance use disorders be difficult?
I think the biggest thing that can be difficult about it is a lack of resources. So, like for example, ASAM has a number of criteria for different levels of care. From outpatient, typical outpatient care, all the way into intensive hospital-based treatment. A lot of the issues with substance use disorder is that there are limited resources in a community. So
Hmm.
if I'm working for Lifestance and I have somebody come in, I do treat people with substance use disorder here at Lifestance. I have people coming in, they may need a higher level of care, with the idea that, okay, once that higher level of care, there's been some stability there, we could come back down to this level of care. But at least in my community, there's not a lot of places to go. There's also this notion in the broader community, and I just mean in society in general, that, oh, you've got to go to rehab, as if
Right.
somehow going to a 28-day inpatient program that most of us could not afford, most insurance will not pay, is somehow going to rectify that. And again, there are some very expensive programs out there, but if you look at their success rate, it is in the single digits. Because what has to happen afterward? Follow up care.
Right.
What about housing? I mean, can a person maintain recovery if everybody else in the home, or even one other person in the home, is using substances themselves? What if, and so we have to kind of look at these systems, the broader systems of care, and also recognize that sometimes people are not ready to stop, even when we really want them to stop. And I'm working with a couple of people right now where it's like, they're asking, do am I an alcoholic? That's their words, and I don't know. You know it, and so so there's a lot of ambivalence a lot of time with folks with substance use disorder. That can make it difficult for clinicians. But the biggest thing I see is a lack of resources. The
Hmm.
thing I like to point out is that when I go to other cities to present, whether it's talking about high risk clients or talking about substance use disorder, I've never gone to a community and been like, hey, all you clinicians out there, you got all the services you need in your community. I've never had a community be like, oh, we've got plenty of geriatric, psychiatric facilities for juveniles, plenty of nobody says that.
No, no.
Nobody says that. And in some states, and Virginia, unfortunately, is one of them, we're in the bottom half.
Okay.
And it's really, it shows. It's a lack of treatment options and a lack of flexibility within that.
How can we fight the stigma surrounding addiction?
I think we tell the stories as best we can. I think part of it is helping clients to understand that this isn't something. This, again, you share what you choose to share. That, anonymity is an important aspect of treatment. It's an important aspect of being able to control your story. Um, but anonymous doesn't mean invisible.
Hmm.
And so what
Hmm.
we are beginning to see around the country is a greater voice coming from the recovery community, even some politicization of that, and saying, we vote too.
Hmm.
Um, and so I think that that's what we have to be able to do is to really understand that there is political capital here. I have a client that I work with here at Lifestance who she lost her son at the age of 18. She found her son and his girlfriend. They were 19, sorry, um, dead of a fentanyl overdose in her house, and uh, obviously uh, tremendous amounts of
Right.
grief, shame.
Of
That's why she
course.
sees me.
Hmm.
But what she has done is she has said, I'm going to lend my voice, and uh, she has testified in front of our state assembly.
Wow.
She has she has reached out to other parents who this has happened to, and she and this group actually have worked to change some laws that are going before our governor here in Virginia to really kind of boost to really in response to this bipartisan, basically
Wow.
saying to folks,
Wow.
we don't care if you're red or blue. This is about life or death, and so lending her voice to that, I think that that's an important piece, and also calmly and nicely. And I got to emphasize that correcting people when you hear them make untrue statements about substance use disorder. I worked a long time, for example, in a clinic that served folks who were homeless
Hmm.
or substandardly housed, and I was part of a workout group at the time, and we were running past an encampment, and one of the guys, it's very wealthy guys in our group, is like, why don't they just go in a shelter? And I kind of jogged alongside him. I said, I hear what you're saying. Can I just let you know this is what it's like inside a shelter? And we talked, and he's like, so why are they out here? I said, a lot of people out here struggle with substance use disorder. That guy he's a multimillionaire.
Hmm.
That guy became a huge advocate for
Wow.
prevention, harm reduction, and he began telling other people, like in the banking industry, hey, we got to leverage some of this. He was already involved in several boards. He got other people involved. It was a calm, kind conversation. It wasn't like, hey, you jerk,
Right. Right.
or
Right.
or it was. By the way, and it's interesting. He told me about a year later he had a friend who lost a child to substance use
Okay.
disorder, and he felt that he was perhaps better equipped from a compassion standpoint to be there for his friend. And I was like, so calm, kind conversations, you know, not slamming people,
Right. Right.
and doing it face to face, not through, you know, Twitter
Social
feeds,
media. Right.
Twitter
Right.
feeds or stuff like that.
Right. Right. How's addiction the biggest issue facing society right now?
Well, if you look at the sheer statistics of it, and the last year we have complete data is 2021.
Okay.
2022 data should be released into this month or in April. 107,000 people died of substance of
You
overdoses
said
in 2021.
107,000.
107,000. So we're talking
Wow.
more than twice the number of people who were killed in all 10 years of the Vietnam War.
Wow.
Um, and we're talking about something that is more than the number of people killed that die by suicide or homicide. And what we're seeing is a 15% increase from 2019 to 2020 to 2021. Now,
Wow.
it's interesting, in 2019 and 2020, we saw a decrease in the overall suicide rate.
Huh.
We did. We
Okay.
saw we saw a slight decrease after 20 years. But what we have seen is this increase, and these are deemed non-intentional overdoses. And again, there probably are some in there that were intentional, just like there are people who die by suicide that are not counted in that number. Okay.
Mhm.
But the fact is that 15% each year. 2022 is projected to be about the same. Over 70,000 of those deaths are due to fentanyl, illicit fentanyl.
Okay.
So when people talk about banning fentanyl, you have to understand fentanyl, as used in a medical setting, is a life-saving drug. If you are in a car accident today, and you are probably going to be given fentanyl because it is very good at reducing pain. It's quick. It's relatively safe. If anybody out there's ever had an outpatient procedure, you had fentanyl,
Okay.
and that's so it's very, very, very safe in that regard. But what we're seeing now is illicit fentanyl that's coming in from overseas. It's coming in all over, not just through the borders, but through the mail. And it was initially used to cut the heroin so that you would have a stronger product. So if you're a heroin dealer, you want to be able to retain your customers. You want to sell good stuff. What
Okay.
we've seen now in most of our cities is that fentanyl has replaced heroin, not just in cities, but in rural areas as well. We're also seeing issues like in the greater Philadelphia area with a drug that on the street is called Trank. It's xylazine, which is actually a veterinary medicine, and that's typically added to fentanyl to extend its effects. We're seeing nitazines, which are other chemicals. These are fentanyl-like, but they're not phenols, that are even more powerful than the various types of fentanyl. And fentanyl itself is 80 times more potent than morphine. And even carfentanil is 100 times more potent than that.
Wow.
So there are
Wow.
literally thousands of different fentanyls and fentanyl analogs, and so people do not know what they're taking, and it's
Mm-mm.
winding up in everything. And the reason it winds up in everything is that typically when drugs move from a production to street level, it's not this nice, neat little chain. It's the
Right.
drugs are probably touched between 20 and 30 times. And every time they're touched, they may be repackaged. There's a lot of cross contamination. And so we're seeing the fentanyl in, uh, cannabis gummies. You can buy a pill press on Amazon for less than 25. So you're seeing in MDMA or ecstasy,
Right.
street
Right.
level alprazolam, cocaine,
Oof. Oof.
methamphetamine, all kinds of stuff. And that's what's leading to that's why this is a huge, huge issue, a major public health crisis.
And there's no way to tell. There's no way to tell
You
that
can
it's in
get,
there.
well, I mean, a lot of harm reduction. I mean, like you can get fentanyl test strips, but they're only going to test if it may not detect other things that are in it.
Okay.
And so when people say, well, gee, why do you keep using? Well, again, the withdrawal profile, particularly from opioids, is extremely, you feel horrible. I mean,
Yeah.
imagine the worst case of food poisoning,
Mm.
and combine that with a full body flu, multiply it by a factor of 3 and have it last 7 to 10 days. And so I tell
Oof.
people, I say, no, listen, when I'm a little nauseous, I'm reaching for the Zofran, you know what I'm saying? Or I'm trying to make a deal with God, please let me throw up. I said,
Mhm.
imagine, and that's just a little bit of discomfort. You're going to want to
I
do,
hear you.
you want to do everything you can. And it's that desire to go back and continue using that drives it. They're not getting high anymore. They're just using not to get sick.
So I think that's a really interesting point there that people maybe don't understand that they're not using to get high anymore. They're
No.
just trying to avoid that. It just sounds like terrible, awful
Yep.
sickness that goes with it, the
Yeah, we call it we
withdrawals.
call it dope sickness.
Hmm.
Beth Macy, who's from Virginia, has a book called Dope Sick, which is really good. I recommend it. There's also a TV series based on it on Hulu with Michael Keaton. And it
Uh,
really, I mean, that we call it dope sickness, and that's really what it is. And it drives a lot of that. And it's even some of the misinformation about substance use treatment that's still within the community is like, well, if I just get the substance out of my body, if I just go through detox, then I'll be fine. That's a very small part of it. In fact, detoxification alone or withdrawal management alone is not really treatment. It can be a beginning part of it.
mhm.
But treatment can begin while the person is still using or even using at a reduced amount. But the idea being that if we just get the drug out of the body, then they're going to be okay. No, there are residual effects that take months or years to address. And that's the post-acute withdrawal that we have to deal with. And it's not even just about getting through the physical symptoms, it's the emotional symptoms. It's
Mhm.
learning to live with, or, having to now examine trauma and things like that.
Ooh, having to examine that trauma without the typical thing you would go to numb your
Correct.
emotions surrounding trauma.
Exactly.
Yeah.
Exactly. Yeah,
Mhm.
absolutely.
How can working in this field be rewarding?
You meet the most interesting people. No, in all seriousness, that's true. It's rewarding because you realize that a lot of people that have substance use disorder, I mean, I describe them as survivors.
Mhm.
And you realize we're not. I mean, I'm only, I'm one or two opportunities or choices or situations away. It's not about them and us; it's about we.
Mhm.
And so I think it's the opportunity to walk with somebody as they go through transformational change, um, and to realize it really is a whole person change. It's not just a changing of behaviors.
Mhm.
It's changing how one thinks. There's a spiritual component that is also very important, and that I think is exceptionally just a part of it. Let me give you an example.
Yeah, please.
I was doing group one time in a program here in Central Virginia called Caritas, and I was running a group as part of another job I had where I work with folks with co-occurring disorders, and I walk in the room and there's a guy sitting there and he's a few years older than probably about 10 years older than me. I introduced myself and he goes, are you the teacher? I said, no, I'm facilitating this group, and we just started talking and I said, you look like something's bothering you. He goes, yeah. He goes, this guy bumped me in the lunch line. This is a live-in. This is a residential program, and
Okay.
they stay there for about 7 months. And he said, this guy bumped me in the breakfast line this morning. And I'm trying to determine if I'm going to go stab him or not. And I said, okay, why would you want to stab him? He goes, well, I spent 25 years in prison. And he said, and if somebody does that to you in prison, you've got to stab them or they're going to come at you. I said, but you're not in prison. He goes, you're right. He goes, you're right. He said, but I'm trying to get my mind thinking right. Because he was using even when he was in prison, because you can get the stuff in there.
Right, right.
And in this program, he wasn't. And he was like, I'm trying to get my mind right. You see, I spent time with my grandkids this weekend. I want to be there for them. He said, my old way is I had to go stab this dude. My way is I'm not. And I said, but if you stay in this room, you won't for at least the next hour. He didn't. And he actually emerged as a group he emerged as a leader in this group. And a few weeks later, some new people were coming in, and he's like, hey, Paul's an all right dude, which I took as a high compliment. He kept me from stabbing this other guy the other day, and I was like, I didn't hold him back, but it was this. Let's just sit with this for a while,
Mhm.
and it was, it's just you're realizing it's a really a whole person change, and it is heartbreaking at times. It is, but I do think it's rewarding. The other reason I do like this field is that it's always changing.
Mhm.
It's and you have to stay on top of it. So it's never static. So that's what's really cool that I like about it. So just what I fell into, I guess.
Yeah. Any other takeaways you'd like to share?
No, just that I really encourage fellow clinicians out there that maybe this is something that you didn't get a lot of training with in school.
Mhm.
A lot of schools, a lot of graduate, not all graduate programs, but there's still many counseling, psychology, medical, social work programs that really just leave this as an elective. And I know, like, for example, here in Virginia, you can obtain your licensed practice independently as a clinical social worker without having really any knowledge or treatment of substance use disorder. And some states are changing that in response to the addiction crisis that we're seeing right now. And and mandating it more and more. And I think that's good. A lot of folks though, so I'm speaking to, a specific group here. A lot of folks may be fearful of going into this because it feels like an entirely new and different thing.
Mhm.
Um, and again, I am promoting a book. I'm being honest about it, but I wrote this absolutely with a mindset of I want to expand the number of people that are treating clients with substance use disorder. This is a place to start.
Yeah.
Is it going to make you an expert? No. I don't consider myself an expert. But I think it's a place to start. Hopefully, it will demystify this process for you, and really make it easier to have conversations with clients. It is a workbook format, so there are tools
Love
within it
that.
that you can
Makes
utilize.
it practical then for
It absolutely
clinicians.
makes it practical. And so my thing is that I really wanted it to be the publisher, the Pessy Media and Publishing. I really wanted it to be that way. And so
Mhm.
there's a lot of material in there. There's some things that clinicians can work on themselves, practice. There are things that you can share with clients. There are activities you can do with clients. And so the idea is that it's designed to really make it easier to begin broadening the way you're working with clients and things like that.
My gosh, Paul, thank you. Thank you for
Sure.
sharing your knowledge and insight on this topic. And I want to plug your book again, The
Sure.
Clinician's Guide to
It's
Substance Use Disorders. Oh,
That's right. It's purple.
love it.
It's purple. And you
Practical
can
tools for assessment, treatment, and recovery. So yes, we're
and
gonna
you can
embed this in the social media
okay.
link too.
Okay. And so you can find it at pesi.com, pesi.com. You can also find it on Amazon. So if you have Amazon Prime, you can get it with a free shipping. And I think Amazon, the cover price is $37. I think Amazon may drop it a few bucks here and there, but Amazon.com, and you can just put Clinician's Guide to Substance Use Disorders. It's purple. I liked purple.
Yep.
My first book is called High Risk Clients. It's a little bit smaller. It's fiery red and orange, and so I wanted something cooler this time. So,
Yeah,
but you can check
purple.
them out.
Yes, no, thank you. And I'd love to have you back on to
Yeah.
maybe do another aspect of talking about actual treatment and recovery
Mhm.
from substance use disorders. I think that would be a great
Sure.
next episode with you.
Sounds good.
So thank you again, Paul.
Thank you.